Hi, I'm Ruben Strayer. I'm an emergency physician and addiction physician living and working in Brooklyn at Maimonides Medical Center. Emergency clinicians manage the consequences of alcohol use disorder on every shift. In addition to the repercussions of alcohol intoxication, which in many departments are so common as to feel ubiquitous, the emergency room is the primary venue of healthcare and in some cases the only venue of healthcare for many people with the devastating disease of alcohol use disorder. Emergency care clinicians are therefore ideally positioned to intervene on this highly prevalent, highly treatable condition. Once you've identified your patient as having alcohol use disorder, engage them to treatment. We in emergency medicine have long focused on the treatment of alcohol withdrawal syndrome and on the medical complications of chronic alcohol use, like Wernicke's encephalopathy and variceal bleeding. But we are uniquely able to treat the underlying problem of alcohol use disorder using medications that address the cravings that lead to compulsive alcohol use and therefore reduce its attendant harms. One of the first-line medications in the treatment of alcohol use disorder is naltrexone. Naltrexone is a mu receptor antagonist. It's like a long-acting naloxone, which we, of course, use to treat opioid overdose. It is effective as an anti-craving medication to treat alcohol use disorder by interrupting the brain's reward cycle, which uses our endogenous opioids, endorphins, to stimulate cravings. People who drink alcohol while prescribed naltrexone feel the effects of alcohol but get less pleasure from it. And over time, by attenuating the reward, the cravings for alcohol use are diminished. Daily naltrexone results in fewer drinking days and less heavy drinking with a number needed to treat of about 12. So it's not a miracle cure, but it's effective. More effective than many other medications routinely used in medicine, with few associated harms. Almost every patient who wishes to reduce their alcohol use should be treated with naltrexone. The main contraindication is opioid use disorder or use of long-term opioids. Ask your patient if they use opioids every day, either prescribed or illicitly obtained, as you explain that if they do and they take naltrexone, naltrexone will cause opioid withdrawal. Some people don't recognize their prescription pain medications as opioids, so ask, do you take any medications for pain? Be cautious in using naltrexone in patients with decompensated liver disease. This caution does not apply to individuals with elevated liver enzymes alone, and LFTs do not need to be checked prior to prescribing naltrexone. And that's it for cautions. Anyone who wants to drink less, who doesn't use opioids every day, who doesn't have severe decompensated liver disease is a good candidate for naltrexone. The dose is 50 milligrams orally every day or a monthly intramuscular injection of 380 milligrams. The most common side effect is GI symptoms that are usually mild. Occasional patients can develop bothersome changes in mood, but most tolerate naltrexone very well. Let's talk more about injectable naltrexone. Naltrexone is available as a long-acting intramuscular preparation that is administered once every 28 days. This, of course, improves adherence, so if this is available in your practice, it may be a good option to discuss. There are two other FDA-approved medications for alcohol use disorder in patients who have a contraindication to naltrexone or where naltrexone isn't tolerated or effective. Acamprosate is probably the next most effective agent. Acamprosate is renally cleared, so it can be used in decompensated liver disease. It's dosed as 2 pills 3 times per day, which is relatively inconvenient and may be cost prohibitive for many patients. Disulfiram isn't properly an anti-craving medication, it's an aversive therapy, as it inhibits aldehyde dehydrogenase, which causes the patient who drinks to become very ill. This disulfiram ethanol reaction can be so severe as to sometimes be dangerous, and adherence to disulfiram is predictably low outside of supervised settings. But there are some people who succeed with disulfiram, so if you see a patient who has done well with disulfiram in the past, I wouldn't hesitate to represcribe. Effective non-FDA approved medications for alcohol use disorder are topiramate, gabapentin, and baclofen. Topiramate can be effective for patients who haven't had success with alternatives, but has to be titrated slowly for its neurologic side effects. Gabapentin is an emerging anti-craving treatment that has the benefit of also treating withdrawal symptoms. The anti-craving dose is 300 to 600 milligrams 3 times daily. For younger patients with high volume use, favor 600 milligrams. And for patients older than 65 or lower volume of alcohol use, use 300 milligrams. Gabapentin accumulates quickly in renal insufficiency. Avoid gabapentin in your patients with kidney disease. Gabapentin can also be used in the treatment of acute alcohol withdrawal syndrome in low-risk individuals. All of these medications can be combined for individuals who need additional support. These anti-craving medications can be continued by outpatient addiction care or primary care. But even if you're not sure if the patient will follow up, prescribe, because too few individuals with alcohol use disorder are receiving these medications. Even if you don't think the patient has high motivation for recovery, if they express a desire to reduce their alcohol use and they'll accept a prescription, prescribe. The benefits almost always outweigh the harms because the harms of long-term alcohol use are enormous. And the emergency department is a crucial venue to intervene on these harms by initiating medications for alcohol use disorder because the emergency department is where these patients are.